right, welcome back to Patient Win Insider. I'm Nick Moen. Today I'm joined by Dr. Ryan Grant, a neurosurgeon turned serial healthcare entrepreneur and the founder of Vori Health, a nationwide virtual first musculoskeletal medical practice that's redefining how we diagnose, treat, and prevent unnecessary surgery. Dr. Grant's built multiple category shaping companies across healthcare, staffing, devices, and value-based care, raising hundreds of millions of dollars along the way. Let's get into it. Thanks for coming on, Dr. Grant.
Thanks for having me, Nick.
So you went from neurosurgeon to founding multiple healthcare companies. What was the moment when you realized that, clinical practice alone wasn't enough and you wanted to go in and fix and disrupt the system?
No, that's a great question. I really view entrepreneurship really as a mindset about how do you help solve problems, sometimes making the problem go away or just getting better solutions, and loved operating in the operating room. But being a full-time surgeon and a startup CEO were not compatible. Surgery is a sport, so if you want to be really good at surgery, you need to practice and do it often. And so it wasn't that I didn't want to be a surgeon. I also wanted to pursue this because I thought that I could touch a lot more lives. So part of what drives me is, can you reach thousands and millions of people over time? That's not something you could do as an individual surgeon. And so I wanted to be able to reach more people. And that was something that was important to me, which sort of what led to some of the decisions of why step away from clinical practice to go in on this full time.
So was kind of the through line that brought you to these ventures, in the mission there of reaching more people, was it like a frustration or more of a curiosity?
It's a mixture, I think. If you're working inside of a hospital or any large organization, there are always things that you can do better. And so I found the health systems that I work for, like sort of like labs. So if you would walk around and see hundreds and hundreds of problems every day, any of us who've been to the airport would be like, how did we could make TSA better, we could make this better, we could make the wait better, we could probably make boarding the airplane better, and all sorts of things that you can make better. And do you become passionate enough about and curious enough about why does the problem exist? Does it bother you as much as other people? And if you start to become literally obsessed with it, where you can't stop thinking about it, you might be onto a good idea. Now in healthcare, 89% of the solution is an execution play. Their ideas are everywhere. And so then it gets down to, how are you going to do it? Who's tried this before? It's rare that an idea is novel. Usually somebody else has thought about it and it either didn't work, or the timing was off, or people have done something similar in a different industry. Like when Henry Ford built the Model T, he really copied the horse slaughtering assembly line to bring that into automobiles. And he used Japanese black paint because it dried so quickly. So his famous quote was, you can have any car you want as long as it's black.
Yeah.
And it was designed so that you can move along the assembly line quickly. So took various parts of ideas and put them together to build something new. And one that I think of often every time I go to the airport is, how many decades did people complain about how heavy their luggage was until someone one day was like, why don't we just put wheels on them?
Yeah.
Like, how many years went by? How many millions of people complained about their heavy luggage? And someone one day was like, why don't we just put wheels on it? I'm going to go build that.
Yeah. Well, I mean, and with Vori, I guess the unaddressed issue there was, preventing unnecessary surgery. Well, what opened your eyes to that reality?
It's a great question. Lots of different things. As I trained in spine and neurosurgery, not everybody got better. So it was a curiosity of, are we always taking the right people to the operating room? These are people's loved ones. Surgery has complications. So some people get hurt once in a while. Some people die. Not usually in the operating room, but within the first 30 days. It's rare, but it happens. And so it gets you into perspective of anyone you take to the operating room, you better be certain that nothing else will work for them, because there is a risk of really bad things happening. And don't forget, these are people's parents and aunts and uncles and husbands and wives and make sure that you decrease the chance that you hurt their quality of life. The whole goal is to do no harm. And so part of it was taking a step back. How do we have less people come here? Because if people can get better without surgery, that's great for them. They avoid the risks of surgery. How do you maximize somebody's quality of life? And are there other options out there? Like I was always taught about physical therapy and surgery, and that was sort of all we really talked about in training. But there's a lot more out there. As you go through the entire globe of medical evidence, there is pain reprocessing, which is how do you help somebody think differently about their pain? There's pain psychology, and there's physical therapy, and there's functional medicine, and there's physical medicine rehabilitation, and there's sports medicine, and surgery is this tiny little piece of it. And so it gets you very curious as you go through and do this big audit. How should we practice? Like, if you could do anything and build a system from scratch, how do you really practice? And the evidence starts to really point towards real care teams. Everybody says they have a care team, but when you usually audit, most folks I usually find are advertising a marketing care team. And what I mean by that is if you have an accountant, Nick, and a lawyer who does work for you, they're both on Nick's team. But does the accountant and lawyer ever talk to each other? Unlikely. Yeah. And so if you have a healthcare team assigned to you, sure, you might have a primary care provider and a specialty physician and a physical therapist and all of these people assigned to a patient. Is the actual healthcare team talking with each other, communicating with each other? Are they actually practicing as a team, or are they just a collection of individuals who are assigned a person? So we wanted to make sure that we were using real care teams who actually talk to each other, work together. Next thing to take a step back on was, are surgeons really the right people to be pulled so upstream? Like, I'll be the first to admit, as a board certified spine surgeon, I am not the best to be the first physician for anything that's non-operative. There are physicians who are better trained in non-operative conservative care than I am. That's physical medicine rehabilitation. The analogy would be that's equivalent to what the cardiologist is compared to the cardiothoracic heart surgeon. And then having those physicians work really closely with the physical therapist, because physical therapists can render what's called a functional diagnosis, movement, and a medical doctor can render a medical diagnosis through a holistic, evidence-based biopsychosocial model. And you start to get some pretty cool things happening when you use the right providers who practice differently and infuse the best of knowledge that's out there. You can get quite a few people better that I was never able to as a solo practitioner in elite hospitals.
Right. I mean, was there like a single patient or a single case that like fundamentally shaped how you see patient care in this way?
No, it's a good question. I think it's more like just it's evolved over time. Like don't get me wrong, surgery can do some really wonderful things for folks. And we at Vori, we still refer people onto the surgical arm. It's just a lot lower. It's about 90% lower than usually the community will have. And so surgery has its place. My own practice used to be big scoliosis, like really large surgeries. And if you pick the right people and who have the right mindset, you can really, really do some wonderful things to improve their quality of life. But again, on the surgical arm, there's increased risk of infection and paralysis. And so that needs to be a last resort because people can get hurt. That's just ethically what would be the best thing to do. For if that was your brother or sister and you know there's a chance of paralysis, well, that should really be the last resort. And so making sure that we've exhausted all of the things that are non-operatively, but that goes beyond just physical therapy. There's a lot more things out there. Physical therapy is a component of what's needed to help people, but it's not the only thing. And so it's the pain psychology and the PT and the health coaching and the biopsychosocial model. 30-40% of musculoskeletal orthopedic conditions have a weight component. Like if you're 100 pounds overweight, your back is going to hurt. Sure. That's like what's one of the first things pregnant women complain about is their back. That extra weight pulls your center of gravity forward, and guess what? Your back hurts. And so helping all the different things. Some foods can be inflammatory and cause joint pain. Sometimes allergies that people have will actually show up as joint pain. And so just taking a holistic viewpoint of a person of how do you get them back to the quality of life they want, improve their quality of life, and just help them live in a better way. And if surgery does make sense, then that's the very last resort, but majority of people won't end up needing to go down that route.
Yeah. Well, I mean, and you mentioned the problem you're solving is unnecessary MSK surgeries. And I mean, can you give some root causes? I mean, are they misaligned incentives or training or patient?
Yeah, I've reflected on this a lot. So I don't think anyone at large is trying to be malicious. Let's put that out there. I don't think anybody's trying to be a bad actor at the end of the day at large. This is a system that's developed over decades and decades and decades. And you can go all the way back to pre-World War I, World War II, when Blue Cross and Blue Shield were separate, before we even had health insurance, and just follow this over time. And we'll concentrate on the United States for the second, is the United States has gotten better and better, as have other countries, at getting surgery smaller and smaller, more minimally invasive. What we have not done a great job at, in my opinion, is indications. Who should actually get on the table? What actually is non-operative conservative care mean? Do we actually do the right body part? Et cetera, et cetera. So I'll give you an example. Let's do low back pain. So lower back pain is one of the most common causes of disability across the planet. It's a top Google search. At large, in the medical community, we've made the assumption, and sometimes we built this into health plans, utilization management, that lower back pain and lumbar spine are synonymous terms. So when you touch your lower back, yes, the lumbar spine's down there. That's great. The first question to ask, how often in a population does the lumbar spine actually generate low back pain? It's not 100%. Some studies would say only 70%. Some would say 80. Some would say 85. There's some of the medical literature, 25 up to 25 to 30% of lower back pain can come from the pelvis, where the lumbar spine inserts something called the sacroiliac joint, or sometimes the hip. So I'll give a patient who's come in not too long ago, lower back pain, terrible. They went through physical therapy. They did a lumbar spine program. They then get an image, an MRI, that shows stenosis and disc bulges. One surgeon wants to do an L4-5, that's just lumbar number 4, lumbar number 5, decompression, open up the nerves. A second surgeon wants to do a L4-L fusion, so open up the nerves and put some screws and rods to hold the bones together. So they come for another opinion. Well, what should we do? So we do this virtually. You examine the patient. You can do the whole physical exam virtually. You don't need to be in person for that. And you're like, we don't think your lumbar spine is symptomatic. And so we think it's actually your pelvis. Well, the person's already signed a consent with the surgeon. So to prove it to them, we send them through what's called a diagnostic injection. It's not designed to last. It's like if you went to the dentist and they gave you Novocaine, lidocaine in your mouth, and that's burning. On the left side, nothing happens. But on the right side, if all your pain went away for 2 hours, guess what? Your pain generator is right where they numbed it up. So we have this, we do an SI joint injection, sacroiliac joint. That's a joint in the pelvis, really like in your butt in essence. And all his pain goes away for 24 hours. And then the numbing medication wears off. So it's like, sir, we just numbed a joint in your butt and all your pain went away for a day. Yeah. That's not even near the lumbar spine. Right. We need to have you go through an integrated program that includes physical therapy. But we're not working on the lumbar spine on this one. We're going to be working on the pelvis. And he got better. And so to your earlier question of what's driving this, are we making the right diagnosis? In the lumbar spine, I don't know that many physicians out there who actually know how to do a sacroiliac joint exam. So there is a training component. It's heavily overlooked, and this has been shown in the primary care provider literature, sometimes the surgeon literature, that this is just something that people don't think about. And so, yes, that's a failure of the education system if it's so common. Going back to the health plans, as things evolved in society, the United States has always been obsessed by technology. Drugs, images, procedures. So yes, over time, incentives have actually driven what makes the most money in the health systems, being inpatient, admitted. But what makes even more money is surgery, procedures. You get paid to do procedures. About 48% of a health system's revenue is elective surgery, according to the American Hospital Association. And so there is a strong incentive to do more procedures. Now, if you have a strong incentive to do more procedures because it pays the bills, you have a strong incentive to train more surgeons. You have a strong incentive to build outpatient surgical centers. You have a strong incentive to have more operating rooms because it's the highest revenue generating. That's just good business, right? Now, through those incentives, do the indications start to get a little gray? Well, maybe they'll get better. Maybe they'll get better with surgery. And so you start to get to these gray cases where you're like, well, because medicine still has an art to it. So now if you have people starting to operate on gray cases, where you're like, it could have gone either way, and that becomes a new standard. Now, if you want to go back to Harvard Business Review 2019 or Lancet, which is a prominent medical journal, some of their updates during COVID, Forbes has covered this, New York Times has covered this, Vox has covered this, the lay press, at the estimate of health systems doing up to 50% inappropriate back surgery. Now, if those systems are doing 50% unnecessary spine surgery, 40% inappropriate knee surgery that doesn't follow the evidence, those are the same institutions that train the new guard. So Dr. Smith, who's 20 years out of training, she's a wonderful, upstanding citizen, is going to do unnecessary surgery, not because she's a bad person. She was taught to.
Right.
And so this is a very, and again, no one's trying to be malicious. Like the current C-suites of health systems have inherited systems that were built before they were sometimes even born, right? Surgeons are trying to do their best. Primary care providers are trying to do their best. They're still, nobody's trying to be harmful. And so the system has evolved into this complex machine that unfortunately results in too much unnecessary surgery, too much unnecessary fusion, not a good understanding of all of the evidence. And you could argue, is that a failure of the medical education system, the residencies, the fellowships, society, expectations? You could spend a whole course in college on this single topic and dissect all of the different complexities. But there's not a single silver bullet that explains versus here we are. And how do we help get people better? At the end of the day, goal at Vori is get as many people as better without surgery. And then those who do meet criteria for surgery and are good candidates, let's help them get to a great surgeon.
Yeah. Well, I mean, you've described Vori as, the solution to this is like value-based care, right? How would you explain that to someone that's unfamiliar?
Yeah, traditionally, value-based care has been a new economic model in the United States where traditionally healthcare has been dispensed. So before insurance, you just paid out of your own pocket. Like you go get a haircut and you pay cash or credit, right? Like that's how medicine used to be practiced. You would just pay the doctor for the care he or she delivered. Then you have the Great Depression who comes forward. The system develops. The average person, why do we have health insurance? Because the average person can't afford healthcare. It's too expensive. It's way too expensive. So now we have this system. And so the current system at large is what's called fee for service. You go to doctor visit or nurse practitioner visit, your primary care provider. He or she sees you. You usually will have a copay or a deductible, and then the insurance will pay part of it. But that provider got a fee for the service. So everything's a la carte. Every visit has a payment. Every day in the hospital has a payment. It's literally like an a la carte restaurant menu. Every little thing. Drugs have a separate menu, separate pricing. So everything's a la carte and you're paid for the services provided. Now in the fee for service, why it gets demonized out there in the news is you are paid no matter what. You're paid if you have let's think about, like if I have a surgical complication, some health plans will pay me again for the surgery to fix my complication. Right. And so you are paid based on volume, not outcome. So value-based care has a rise and has been pushed as a new concept, not a new concept. This has been talked about for decades. But the whole philosophy around it is, are we getting real value? Meaning, are you being paid for the outcomes? Positive patient outcomes, lower infection rates. Now, where value-based care has sat today is where it has morphed is people really think about it as economics. It's like, how did we save dollars? And sometimes I think forget about the ultimate is, are we getting the outcomes we want and are we being paid for them? Now, to do value-based care well, I don't think you can just sign a contract with a health plan and then magically just practice the same, right? So you have to change the way you practice medicine. You have to organize differently. So if you want to do a value-based care health plan contract well or partnership well, you need to be practicing differently than you did on fee for service. Otherwise, what's changing? What's changing? And so are you using the right providers? Is it evidence-based? Is surgery appropriate? Did they do this? Did they do that? And then you are rewarded for patients doing well on getting better, saving society money, and really getting that value. So being paid for value and not being paid again for mistakes. So that's really, in essence, are you getting what your money is supposed to be getting is what the concept of value-based care has been. It hasn't always been well executed out there. And we have a long way to go in society, but there is forward progress, which is what excites me.
What do you think maybe the biggest misunderstanding or misconception of your solution of virtual healthcare? What do you think the biggest misconception there is?
Several different things. Healthcare tends to be like 30 years in the past compared to other industries. Like one of the preferred communication channels still by a lot of health systems is the fax machine. Yeah. Which is crazy. And so people have demonized virtual care, telemedicine care for quite some time. It's calmed down quite a bit, particularly when people were forced to use it during the pandemic. People tend not to respond very well to new things. And so you hear about the virtual versus in-person care. which I also was like, this doesn't make any sense. This is what banking went through back in the day when banking first went online. You can't do banking online. It's dangerous and they'll take your money and it's not secure. Nobody talks about virtual banking versus in-person banking versus hybrid. It's just banking. And then eBay and Amazon, you can't shop online and do auctions online. Nobody talks about virtual shopping versus in-person shopping versus hybrid. It's just shopping. Healthcare is moving towards that, where people are still talking about virtual versus in-person versus this concept hybrid of both. It's just care. And all of us live a hybrid life nowadays. You have a smartphone, you text family members and friends, you do FaceTime, you do Zoom or Teams, and then you go see people in person at the holidays. Family, you see corporate colleagues in person for meetings. Our whole life is hybrid, and so is care. So virtual care is integral. It's not an adjacency. It is integral to the delivery of care, just like it is integral to banking and shopping. We live hybrid lives, and you can't do everything in person. People are like, what? You're not seeing a patient every day in person. That's not realistic. They're not driving to see you every day.
Right.
You can easily touch base with them by text, chat, video, or even with the help of AI. And you can't do everything virtually. Some things need to be done in person. If you need an image, you need to go to an imaging center. If somebody's going paralyzed, they should be examined in person, and they might need an emergency surgery. If you need dry needling or acupuncture or other types of therapy with manipulation, well, that has to be done in person, or someone has to come to your house. And so it's not an either or. It is an integral. And so would love to see people, and this is getting a lot better. It's integral. And I would love to see people stop talking about virtual versus in-person. It's just care. It's about meeting people where they are. It's maximizing how far you can take each modality. And a lot of people, you're going to use every modality, just like we use in our own lives. And you can do a full physical exam at large virtually. So the physical exam doesn't need to be in person usually. It can. And so then some of it comes down to patient preference, but would love to have people stop debating technology and then just maximizing the patient experience and outcomes. And we'll go even faster in terms of how far we can take healthcare reform.
Yeah. Well, and you mentioned AI. So, I mean, it's inevitably involved in virtual healthcare, right? On a digital platform. What do you see as maybe some limiting factors that are underestimated using AI in entrepreneurship, but also specifically in healthcare?
Yeah, it's a great question. I think people need to just make sure they understand what they're trying to solve. I hear a lot of folks talk about, well, I'm going to use AI. You're like, for what? Like you have to be real crisp on what is the problem you're trying to solve. And then there are multiple ways to solution it. But if you start with the solution, AI, and you don't have a crisp problem, that's usually where you get a crappy product, a bad experience, a disjointed. And so got to be really crisp on what are you solving? What is the problem? And then you can be like, well, how can AI be applied to this problem? And et cetera. Because AI can do lots of things. So in the healthcare sector, the ones that you see being tackled the first is back office. So you see AI being used to help clinicians transcribe notes. So it's like they're digital scribes, so they can pay more attention to the patient. There's less typing to do, less dictation. AI captures all of that. And then they have to just go read the note for accuracy. Very similar to those who use Zoom or other types of meetings, or Otter or some of these other things out there that type notes for you. And then you have to proofread them for accuracy, but that saves a lot of time. There is AI being used in the call centers where it can call, it can do a basics like what meds do you take, and reschedule appointments, schedule appointments. So some of that straightforward type of work inside of a call center, and then escalate to a human if you need them to. You have AI who can help you do triage through learning. If you should be scheduled likely with this, because how does scheduling happen right now? Well, it's either by a human who's usually not always trained in medicine,
Right,
or a person just randomly going to a clinician they think might be right, but they don't know, right? So you can actually use AI to make that smarter and more efficient. And then you have billing, revenue cycle management, and on and on and on. AI also tends to be more empathetic. It tends to placate. So you can also use AI to take, for example, a physician's notes, transcribe it into a fourth grade level. It's much easier for people to read, and make it much more personalized to the patient. So using AI for personalization. Then on the patient side, all sorts of stuff. You can use AI as a digital extension of the team, where they can be a mixture of an executive coach, a health coach, someone who's around 24/7, who doesn't get mad at you at 2 a.m. for asking a stupid question. AI is not getting mad at you if you ask them a stupid question at 2 a.m. The doctor you just woke up at 2 a.m. might be a little grumpy.
Yeah.
But if it's well trained, it can certainly escalate of when do you get a human on the line, because AI can't do everything. And then making sure people know the limits. AI is only as good as the data that is sent into it, and it's only as good as the large language module it's been trained on. And then also AI has been trained to placate folks, not disagree with you, right?
Yeah.
Well, Nick, that's a great idea to is it? And so making sure the appropriate guardrails for safety are in place within your modules. Otherwise, we've seen all sorts of stuff in the news where AI can hallucinate if it doesn't have the confined guardrails. And ways to bring hallucinations down is to have things relatively confined versus the massive universe of data that might be coming into it. And so, yeah, AI can be used for tons of good things. It can be used for administrative things, but AI is not a magic. It's not magic. It's not a magic bullet. So if you take a process, if you take a bad process and you digitize and you ask AI to use this bad process, guess what? It will make it worse.
Right. Yeah.
Right? Like if you're just asking it to amplify, unless you're asking, hey, can you help me solve and make this process better? So it depends on what you're asking it to do. But AI can make lots of things better. It can also make a lot of things worse if you're not clear on what you're solving for.
So then what's one area in healthcare that, people might assume AI will fix, but that you believe, will remain kind of deeply human, for the near future?
The clinician patient bond. So I love to see like these like AI scribes where we've all been to it, like whether it's telemedicine or in person, where the physician is looking at they're not paying it fully. They're not making eye contact. And in the office, they're typing on a computer, or on virtual care, they might be typing into the EMR to collect because they're not going to remember the 30 people they saw that day. So they're doing it as they go. But if your scribe catches that, being able to look somebody in the eye and be more present and listen and just be a better clinician, I think goes way up. I think removing some of the administrative tasks that you don't need a doctor or a nurse or somebody to do, and offloading that to AI allows them to, one, operate at a higher level, higher quality, better, improve the quality, and also decrease the concept of burnout where people feel like they're emotionally exhausted. And lots of things that exhaust people are things that are very repetitive and boring, like charting and dictating and typing notes. Nobody likes doing that.
Yeah.
And so offloading some of the things that people don't like doing so that they can enjoy the practice of medicine more is very, very exciting of what it can do to not only improve the quality of care, but improve the quality of lives of our clinicians. And if done well, it should decrease burnout. It should decrease this emotional burnout that people are feeling as you offload some of this work that people didn't sign up for when they went to medical school and nursing school.
Yeah. So what do you think the impact and outcome of your involvement with Vori and MSK care, where is it headed in 10 years? What do you think it's going to look like?
Personalization, regardless if it's musculoskeletal, orthopedics, GI, mental health, primary care. Now, if let's just say everybody starts using AI, right? So everybody's using the same large language modules from OpenAI or Anthropic or Google, etc. It will become even more paramount to stand out of having higher quality as individual humans, like using human ingenuity to be even better than what AI is. Because AI can raise the bar, but if everybody's bar is raised, you need to raise it again.
Yeah.
And that gets into a brand and personalization. Like, what are people most interested? They want great quality, right? People want great experiences. Like, why do you fire your internet provider? Because it keeps going out. And then you call them on the phone to solve it, and the experience is terrible. Like, push 5 to get to the 8. You fill out the stuff, key in your account number, and then the first thing the customer service agent asks you is the same thing that you just typed in. Like, that's a terrible experience, particularly with someone who's irritated. Why do you not want to use an airline anymore? They canceled your flight 4 times, and it wasn't due to weather. Yeah. And you're like, hell with these people, right? And so people will jump from a brand if the core service just doesn't work, right? So it doesn't matter how good your marketing, does the core service work? But what makes people really excited and loyal? You surprise them. You delighted them. They're like, wow, that was really, Think about the restaurants you go back to. You might not always love, you might not even think that's like Michelin star food. You love the atmosphere, the waiter, the waitress, just, you're like, they just take so good care of me. And people have built cruise ships and airline, like what is Virgin Airline trying to do? Just be a better experience. Like there's only really a few manufacturers of airplanes. There's like Boeing and Airbus. That's it for really the big ones.
Yeah.
So everybody has the same set of airplanes and they differentiate on price, customer service, experience, comfort. Hotels, they all have a mattress and a bathroom.
Right.
Like what really is the difference between a 5-star hotel and a 1-star hotel?
Yeah.
The quality of the experience, the quality of the materials, but it comes down to an experience. And so I think 10 years from now, the people who will be winning in all sorts of sectors is, did you really personalize it? Do you know me? Did you delight me? Did you empower me? And do I love your product?
Yeah. Well, Ryan, I feel empowered and delighted. It's been a real pleasure having you on, and I couldn't have had this conversation with AI. I had a great experience.
There you go. There you go. You can ask ChatGPT later.
Yeah, right. Yeah, thanks for coming on. I really appreciate it. Until next time.
Yeah, thanks for having me.